Now I'll invite our next speaker, Dr. Anubha AJ. She'll be presenting recurrent external angular dermoid cyst.
Good morning, everyone. Here is a case report on recurrent orbital external angular dermoid cyst. A 28-year-old lady visited OPD with chief complaints of swelling over left upper eyelid since 6 years. Swelling was insidious in onset. Initially the size of a peanut, has steadily progressed to the current size of grape over the last 6 years with no associated pain or discharge. There was no history of trauma, no associated aggravating or relieving factors. There was history of similar complaints 20 years ago at the same site for which she underwent surgery. No other significant history could be elicited. On examination, 1.5 into 1 centimeter, smooth, firm, round, non-tender with clear margins, mobile under the skin swelling could be palpated in the superotemporal part of left orbit. And a previous surgical scar of about 2 centimeter was also seen. Best corrected visual acuity in both eyes was 6 by 6 and both eye anterior and posterior segment evaluation was normal. MRI revealed a hyperintense cystic lesion along the subcutaneous plane of the lateral margins of the left orbit, measuring 1.4 into 1 to 1.2 centimeter, likely angular dermoid cyst. After necessary investigations, patient was planned for dermoid excision. Intraoperatively, external lateral subbrow incision was given over the mass, and 2 into 1.5 into 1 centimeter cyst was excised in toto, and rest of the surgery was uneventful. After tumor excision, postoperatively, patient was given oral and topical antibiotics with analgesics for 5 days. Postoperative results were satisfactory with a well-concealed heel scar. Suture removal was done after 10 days. Excised tissue was sent for histopathology, which showed stratified squamous epithelial lining with dermal appendages as contents, confirming our diagnosis of dermoid cyst. And then patient was followed up to monitor any complication or recurrence. Coming to the discussion part, orbital dermoid cysts are a type of choriostomas most frequently encountered in children, can be seen in adults as well. They occur due to displacement of ectoderm to a subcutaneous location along embryonic lines of closure. Histopathology shows stratified squamous lining containing dermal appendages like sweat glands, sebaceous glands, and hair follicles. Dermoids can be superficial or deep depending on its relation to the orbital septum. Superficial dermoid cysts present as a painless nodule, mostly in infants and children, frequently in the superotemporal part with features which was seen in the case. Deep dermoid cysts are common in adolescents and adults, present as gradually progressing proptosis or acute inflamed orbit following its rupture or infection. Posterior margins of cyst could be indistinct with associated bony defect or an extension into intracranial and infratemporal fossa. Management of both is by surgical excision in toto without rupturing the wall, as keratin leakage can cause severe granulomatous inflammation or recurrence. So in conclusion, orbital dermoid cysts are one of the most common benign tumors of the orbit. Examination, imaging, and histopathology features help in differentiating from other related lesions like epidermoid cyst and dermolipoma. Superficial and dermoid cysts have different presentation at different age, progression, and associated complications. And surgical excision is recommended to avoid complications like rupture, cutaneous fistula, progression of tumor growth, and bone erosions. Thank you.
Thank you, Dr. Ganjana. How you pronounce your name?
Anubha.
Anubha. Acha. Which one? Acha, co-author, Anubha. All right. So I was just wondering that your case was a recurrent, this thing operated
Yes.
elsewhere.
Yes, ma'am, elsewhere. 20 years ago, elsewhere she was operated.
Okay, so in the discussion, you didn't talk about the causes mentioned in literature. What are the causes? Why you see recurrence in these patients with dermoid cyst?
Recurrence is usually due to incomplete excision of the cyst, ma'am.
And any other reason?
Incomplete.
If it's a dumbbell dermoid cyst, if it
If
has,
it's a deep,
yeah, there is another component either in the orbit, or somewhere else, then and that is not removed, then they can be, recurrence.
Yes.
And the other thing I just want to emphasize here is that dermoid cyst, nowadays we decompress. So don't go by this that we have to take it out in toto and give a, a long, scar. That is not required. So just a small scar, dissect a sufficient amount, a small nick, and you decompress, partially take out the content. And once you do that, you have sufficient surgical space and you can operate and take out the whole cyst. See, the thing is that you have to take out the complete cyst wall in toto. All
Yes.
right. And hardly there is any spillage because it is very superficial thing. So for that you don't have to give a very long, scar over there. So decompression is something which is mentioned in the literature. So it's not that every time, it's not that you have to take out in toto. We
Yes.
do it routinely. You just give a neck, decompress, have a good surgical space, small cut, minimal manipulation, take out the whole cyst wall, the content, and give wash. And there's hardly any leftover spillage there in the surgical site. You can easily see and wash.
Yes.
All right, so that makes it less invasive and a small scar.
Yes. Thank you, ma'am.
Okay.